Hello and welcome. This is our second of the two-part lecture on cell wall inhibitors. In our previous part 1, we mainly discussed penicillins, while now we will discuss cephalosporins, carbapenems, monobactams, vancomycin, and several other agents commonly used in clinical practice across all specialties. Throughout this lecture we will build that knowledge step by step, and a summary at the end. So, let's start. The learning objectives of this lecture are listed here. Please take a look. Although cephomycins and cephalosporins are closely related, there are important differences. Cephomycins possess activity similar to second-generation cephalosporins but add useful anaerobic coverage. This makes them particularly valuable in infections involving mixed aerobic and anaerobic flora. Cephalosporins, on the other hand, are typically discussed in generations. As one moves from first to fourth generation, gram-negative coverage generally expands. This progressive increase in gram-negative activity is one of the defining features of cephalosporin evolution. Understanding this trend provides a useful framework for remembering the properties of different generations. Although cephomycins and cephalosporins are closely related, there are important differences. Cephomycins possess activity similar to second-generation cephalosporins but add useful anaerobic coverage. This makes them particularly valuable in infections involving mixed aerobic and anaerobic flora. Cephalosporins, on the other hand, are typically discussed in generations. As one moves from first to fourth generation, gram-negative coverage generally expands. This progressive increase in gram-negative activity is one of the defining features of cephalosporin evolution. Understanding this trend provides a useful framework for remembering the properties of different generations. First-generation cephalosporins are characterized by excellent gram-positive activity, particularly against methicillin-sensitive Staphylococcus aureus and Streptococci. Their gram-negative activity is relatively limited, primarily covering organisms such as Proteus mirabilis, Escherichia coli, and Klebsiella pneumoniae. Cerebrospinal fluid penetration is poor, making them unsuitable for meningitis. However, tissue penetration into skin, soft tissue, and bone is excellent. Cefazolin is particularly important because of its role in surgical prophylaxis and treatment of MSSA infections. Cephalexin remains a commonly prescribed oral agent for skin and soft tissue infections. Remember that first-generation cephalosporins are often regarded as the strongest cephalosporins against gram-positive organisms. Second-generation cephalosporins represent a heterogeneous group with improved gram-negative coverage compared with first-generation agents. Activity against common respiratory pathogens is enhanced, making these drugs useful for conditions such as sinusitis, otitis media, and lower respiratory tract infections. Cefuroxime is notable because it achieves useful concentrations within cerebrospinal fluid. Certain members of this generation, particularly the cephomycins shown in blue, possess additional anaerobic activity. This makes them useful in mixed infections involving both aerobic and anaerobic organisms. The second generation therefore occupies an intermediate position between the strong gram-positive activity of the first generation and the broad gram-negative activity of later generations. Third-generation cephalosporins are characterized by substantially expanded gram-negative activity. Several members possess excellent activity against serious gram-negative pathogens and achieve therapeutic concentrations within cerebrospinal fluid, making them important agents for meningitis. Ceftazidime is particularly notable because of its activity against Pseudomonas aeruginosa. Ceftriaxone and cefotaxime remain among the most widely used antibiotics in modern clinical practice because of their effectiveness in severe infections such as meningitis, gonorrhea, sepsis, and community-acquired pneumonia. Notice also that several third-generation cephalosporins are available orally, extending their usefulness in outpatient settings. This generation is often considered the workhorse of modern cephalosporin therapy. Fourth-generation cephalosporins are represented primarily by cefepime. This agent combines extensive gram-negative activity with improved stability against many beta-lactamases. Importantly, it also retains useful gram-positive activity. Cefepime penetrates well into cerebrospinal fluid and is active against Pseudomonas aeruginosa. These properties make it particularly valuable in serious hospital-acquired infections, febrile neutropenia, and severe gram-negative infections. Because of its broad spectrum and reliability, cefepime occupies an important position in empirical treatment of critically ill patients while microbiological results are still pending. The fifth generation of cephalosporins was developed to address one of the most important resistance problems in modern medicine, namely methicillin-resistant Staphylococcus aureus, or MRSA. Unlike earlier cephalosporins, ceftaroline is able to bind PBP2A, the altered penicillin-binding protein responsible for methicillin resistance. This allows it to retain activity against MRSA while preserving the favorable safety profile of cephalosporins. In addition, fifth-generation cephalosporins remain effective against many streptococcal species, including strains with reduced susceptibility to penicillin. Their gram-negative activity resembles that of third-generation agents, although they generally lack activity against Pseudomonas aeruginosa. These agents represent an important example of how antibiotic development continues to evolve in response to bacterial resistance. The adverse effect profile of cephalosporins resembles that of penicillins because both belong to the beta-lactam family. Hypersensitivity reactions remain the most important concern and may occur in patients with previous beta-lactam allergy. Gastrointestinal disturbances and superinfections can also occur due to disruption of normal microbial flora. Certain cephalosporins contain a methylthiotetrazole side chain that produces distinctive adverse effects. These include hypoprothrombonemia, which may increase bleeding risk, and a disulfiram-like reaction when alcohol is consumed. Patients receiving such drugs should therefore be advised to avoid alcohol during therapy. Recognition of these unique toxicities is particularly important because they are frequently tested in pharmacology examinations. The summary table integrates these differences and serves as an excellent framework for comparison. When viewed together, these generations illustrate a progressive evolution of spectrum and clinical utility. First-generation agents provide the strongest gram-positive coverage but relatively limited gram-negative activity. Second-generation agents increase gram-negative coverage and add some anaerobic activity. Third-generation agents substantially expand gram-negative coverage and achieve excellent cerebrospinal fluid penetration. Fourth-generation agents combine broad gram-negative activity with anti-pseudomonal effectiveness and improved beta-lactamase stability. Finally, fifth-generation agents introduce MRSA coverage through activity against PBP2A. Carbapenems are often regarded as the broadest-spectrum beta-lactam antibiotics currently available. Their activity extends across many gram-positive organisms, gram-negative organisms, and anaerobes. Agents such as imipenem and meropenem also exhibit activity against Pseudomonas aeruginosa. Another important characteristic is their excellent penetration into cerebrospinal fluid, making them useful in selected central nervous system infections. Carbapenems are resistant to many beta-lactamases that inactivate penicillins and cephalosporins. However, they are vulnerable to carbapenemases, including serine carbapenemases and metallo-beta-lactamases. Because of their broad spectrum and reliability, carbapenems are frequently reserved for severe or resistant infections where narrower agents may be ineffective. Imipenem possesses excellent antibacterial activity but has one important pharmacokinetic limitation. Within the kidney, it is rapidly degraded by an enzyme known as dehydropeptidase 1, which is present in the brush border of renal tubular cells. To prevent this degradation, imipenem is administered together with cilastatin. Cilastatin itself has no antibacterial activity. Its sole purpose is to inhibit dehydropeptidase 1 and thereby protect imipenem from renal metabolism. This combination increases urinary concentrations of active drug and prolongs therapeutic effectiveness. Understanding this partnership is a classic pharmacology concept that frequently appears in examinations. Carbapenems are generally well tolerated, but adverse effects can occur. Local irritation and skin rashes are relatively minor manifestations. The most clinically important toxicity is neurotoxicity, particularly seizures, which occur most commonly with imipenem. The risk is increased in patients with renal impairment or pre-existing neurological disease. Despite these concerns, carbapenems remain among the most valuable antibacterial agents available. They are frequently used as empirical therapy in critically ill patients because they provide exceptionally broad coverage. They also play a major role in treating infections caused by ESBL-producing organisms, with meropenem being one of the most commonly used agents for severe ESBL-associated infections. Aztreonam is the only clinically important monobactam. Structurally, it differs from other beta-lactams because it contains a single beta-lactam ring without the fused ring system seen in penicillins, cephalosporins, and carbapenems. Its antibacterial activity is restricted primarily to aerobic gram-negative organisms, including Pseudomonas aeruginosa and Serratia species. One of its most useful characteristics is its minimal cross-reactivity with penicillin allergy. Consequently, aztreonam provides an important therapeutic option for patients who require gram-negative coverage but cannot safely receive other beta-lactam antibiotics. Although its spectrum is narrow, its unique role makes it clinically valuable. Over the years, resistance against antibacterial drugs has evolved to the extent that it has become a critical issue globally. Because beta-lactams make up over 70% of total antibacterial consumption volume, bacteria have rapidly mutated, rendering standard therapies increasingly ineffective. Bacteria have evolved several mechanisms to resist beta-lactam antibiotics. Production of beta-lactamases destroys the antibiotic before it reaches its target. Extended-spectrum beta-lactamases can hydrolyze many penicillins, cephalosporins, and monobactams. Carbapenemases further extend resistance to carbapenems. Additional mechanisms include altered penicillin-binding proteins, reduced drug entry through porin modifications, and active efflux pumps. These resistance mechanisms continue to drive the global challenge of antimicrobial resistance, necessitating strictly judicious use of antibacterial drugs. Vancomycin belongs to the glycopeptide class of antibiotics and occupies a unique position among cell wall synthesis inhibitors. Unlike beta-lactams, which bind penicillin-binding proteins, vancomycin acts by binding directly to the D-alanine termini of peptidoglycan precursors. This prevents incorporation of these precursors into the growing cell wall and ultimately inhibits cell wall synthesis. Because its target differs from that of beta-lactams, vancomycin remains effective against many organisms that have developed resistance to beta-lactam antibiotics. This distinctive mechanism explains its importance in the treatment of serious gram-positive infections, particularly those caused by resistant organisms. Vancomycin is derived from Amycolatopsis orientalis and exhibits activity primarily against gram-positive organisms. Its large molecular size prevents effective penetration through the outer membrane of gram-negative bacteria, which explains its lack of activity against most gram-negative pathogens. Oral absorption is poor, so systemic infections require intravenous administration. Intravenous vancomycin is widely used for serious MRSA infections, including bacteremia, endocarditis, osteomyelitis, and severe skin and soft tissue infections. Oral vancomycin, however, has a specialized role in the treatment of Clostridioides difficile infection because the drug remains within the gastrointestinal lumen where the pathogen resides. In the presence of meningeal inflammation, vancomycin can achieve therapeutic concentrations within cerebrospinal fluid. Although vancomycin is an extremely valuable antibiotic, several adverse effects deserve attention. One of the best-known reactions is red man syndrome, which is characterized by flushing, erythema, itching, and occasionally hypotension. This reaction is not a true allergy but results from rapid histamine release during infusion. The risk can be minimized by administering the drug slowly over an extended period. Nephrotoxicity and ototoxicity are potential concerns, particularly when vancomycin is combined with other nephrotoxic or ototoxic medications. Because vancomycin is distributed widely throughout body tissues and is eliminated primarily by the kidneys, Monitoring of renal function is recommended during prolonged therapy. Plasma level monitoring is also commonly performed to ensure efficacy while minimizing toxicity. Teicoplanin is closely related to vancomycin but offers the advantage of less frequent dosing and the possibility of intramuscular administration. We now turn our attention to two less commonly used cell wall synthesis inhibitors, bacitracin and cycloserine. These drugs act at earlier stages of peptidoglycan synthesis than beta-lactams or vancomycin. Although their clinical applications are more limited, they remain important because they illustrate additional vulnerable points within the bacterial cell wall synthesis pathway. Studying these agents also reinforces the concept that multiple enzymatic steps are required for successful construction of a bacterial cell wall. Bacitracin consists of a mixture of polypeptide antibiotics produced by certain strains of Bacillus subtilis. Its mechanism of action involves interference with bactoprenol recycling, a process required for transporting peptidoglycan precursors across the bacterial cell membrane. Without an effective transport system, cell wall synthesis cannot proceed. Bacitracin demonstrates activity primarily against gram-positive organisms. However, its clinical usefulness is severely limited by marked nephrotoxicity when administered systemically. Consequently, modern use is almost entirely restricted to topical formulations for skin and mucosal infections. Despite its limited systemic role, bacitracin remains an important pharmacological example of inhibition at the membrane transport stage of cell wall synthesis. Cycloserine is a cyclic amino acid analog that acts by interfering with D-alanine metabolism. D-alanine is an essential component of peptidoglycan synthesis, and disruption of its formation prevents proper assembly of the bacterial cell wall. Cycloserine exhibits broad activity against both gram-positive and gram-negative bacteria, but its principal clinical role today is as a second-line agent in the treatment of tuberculosis. The major limitation of cycloserine is neurotoxicity, which is dose-related and may manifest as irritability, depression, psychosis, seizures, or other neurological disturbances. Because of these adverse effects, cycloserine is generally reserved for situations in which safer alternatives are unavailable or ineffective. Phosphomycin targets one of the earliest stages of peptidoglycan synthesis. Structurally, it resembles phosphoenol pyruvate and acts by inhibiting the enzyme MURA. This enzyme catalyzes an essential step in the formation of N-acetylmuramic acid, a fundamental building block of bacterial cell walls. Because MURA functions near the beginning of the synthetic pathway, inhibition prevents production of downstream peptidoglycan components. Phosphomycin therefore represents an excellent example of how antibacterial drugs can target precursor synthesis long before assembly of the mature cell wall begins. Phosphomycin possesses activity against a broad range of gram-positive and gram-negative organisms and frequently demonstrates synergistic activity when combined with other antibacterial agents such as beta-lactams, aminoglycosides, and fluoroquinolones. One of its most useful pharmacokinetic properties is its ability to achieve very high urinary concentrations. These concentrations often exceed the minimum inhibitory concentrations of common urinary tract pathogens by a considerable margin. For this reason, phosphomycin is widely used in the treatment of uncomplicated urinary tract infections. A particularly attractive feature is that uncomplicated cystitis can often be treated with a single oral dose, making therapy simple, convenient, and highly effective. This slide summarized the entire lecture in terms of their mechanism and clinical implications. This summary slide integrates many of the practical concepts discussed throughout the lecture. It serves as a bridge between basic pharmacology and clinical application, helping transform mechanistic knowledge into practical understanding. We have now completed our discussion of antibacterial drugs that inhibit bacterial cell wall synthesis as a lecture series. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!